Welcome, everybody, people in person, people online. I am not one of the chief residents, but I think the chief resident who's going to introduce Dr. Gurol is unable to come in person, and it's just my pleasure. Rather than reading anything, I will, luckily I'll be short to allow the speaker to have full time, but it's just a real pleasure and honor to introduce my friend and colleague of many years, Dr. Edip Gurol. Edip completed neurology and stroke training in Turkey before coming to the U.S. As a fellow, I think originally with Walter Korschutz, if I'm remembering right, and then became involved in our group and did something that's really challenging to do, which is to re-credential himself, even though he was already a trained stroke neurologist, to re-credential himself by repeating residency, sort of a nightmare for many of us to imagine, and the same perseverance that Edip showed in going through the training to allow him to be able to practice medicine in the U.S. has also shown up in his research, which has been tremendously influential. His national and really international leadership in the fields of high hemorrhage stroke risk and neurocardiology is a real pleasure for me as one of Edip's early mentors and now colleagues to have watched. So, and I know that will be the subject of Edip's talk, so you will get to judge for yourself. But from my standpoint, it's just a real pleasure to have been able to work with Edip for these years and to watch him grow as a national and international leader. So with that, I welcome my friend and colleague, Dr. Edip Gurol.
Thank you very much, Steve, for the always generous introduction. So yeah, we are going to discuss cerebral small vessel disease and atrial fibrillation. Yeah, that all I did was to try to confirm some of Steve's hypotheses from 1990s. I probably had a little bit of a different flavor, but really Steve put together the whole field of cerebral immune angiopathy and then small vessel diseases, bleeding risk. So you are going to see, you will see his name on most of the papers that we will be discussing today. Okay, so this is about the attendance, accreditation, the learning objectives. And this one is about the disclosures. So I'm mainly National Institute of Health Fund sponsored, but I've also had some research grants directly to the hospital from a number of industry partners as well, as you can see. So we're going to start out by discussing cerebral immune angiopathy and hypertensive small vessel disease, which is going to be really brief. Most of you guys here know about the entity and the Boston criteria. So Steve came up with the Boston criteria back in 2001, which got a update in around 2009, 2010. As the great majority of the studies performed used these two criteria. I'm going to discuss those briefly. So in patients of 55 years of age who sustained a lower intracerebral hemorrhage, if you get a autopsy and if it shows severe CAA, okay, this is definitely CAA. If such patients get their hematoma evacuated and the neurosurgeon is kind enough to send a little bit of a piece for pathology examination, and if it shows significant CAA, then it's again cerebral immune angiopathy. The probable CAA is a probable and possible CAA are the categories that we use most often in clinical practice. So in people over 55 years of age who had a lobar intracerebral hemorrhage, who do not have any other reason for having a lobar intracerebral hemorrhhage, who have either a cortical microbleed or multiple strictly cortical microbleeds, or who have different regions with superficial siderosis, the diagnosis is probably CAA, and it has a very high accuracy for this diagnosis. Possible CAA happens when a patient has lobar intracerebral hemorrhage, no other reason for it. The patient is over 55 and there is no other hemorrhagic lesion. So the newest version of the CAA criteria incorporates some ischemic markers as well, but we are going to be discussing how the ischemic markers came under the light. So I'm not going to discuss the latest version of the Boston criteria for CAA. Hypertensive deep intraparenchymal hemorrhage. It's been known for over 100 years, and we learned from the work of Dr. Miller-Fisher a lot on this entity. It's the most common cerebral small vessel disease and intracerebral hemorrhage type. So when a hypertensive patient with non-traumatic hemorrhage in deep hemispheric regions is a non-traumatic hemorrhage in deep hemispheric regions such as basal ganglia or thalamus or brainstem, in the absence of other pathology, this typically represents hypertensive small vessel disease related to cerebral hemorrhage. With CAA, the average recurrence risk is about 10% per year. With hypertensive ICH, the annual recurrence risk is about 2% per year. So when I joined Steve's lab back in towards the end of 2002, in 2003, the thing that was really it's one interesting question was the ischemic effects of cerebral small vessel diseases. And Steve was already entertaining the idea, the question of vascular dysfunction and their effects on cognitive impairment. So my early work and later work included a lot of mechanistic studies in populations with cerebral angiopathy who underwent advanced neuroimaging. When I joined, it's mostly qualitative methods to identify and classify the severity of white matter disease was used. It took me about a year for me to come up with computer-assisted ways of quantifying white matter hyperintensities. That certainly gives you more power to detect differences. It's a lot more precise method where you get the volume of the pathology in milliliters. And this initial study showed a significant association between cerebral angiopathy diagnosis and white matter hyperintensity volume, even after adjusting for potential confounders when compared to Alzheimer's disease patients and mild cognitive impairment patients. We also showed the same thing later on when we compared CA to healthy control. CA patients had a lot more white matter hyperintensities. And these methods have been used since then. And another study that we did back then showed a rather significant worsening in white matter hyperintensity volume, even over 1 year in patients with cerebral angiopathy. And the severity of baseline white matter disease was associated with new MRI, GRE-defined hemorrhages, microbleeds, and intracerebral hemorrhages. We got more sophisticated over the years, and we started to use CRISPR company to identify, to tag brain amyloids, and we clearly showed that CRISPR compounding was binding vascular amyloids as well as it was binding pancreatic amyloids. This study was an interesting one. It was published in Annals of Neurology, and here we show that there was a very significant association between vascular amyloid loads and white matter hyperintensity volume only in cerebral angiopathy patients, but not in Alzheimer's disease or mild cognitive impairment patients, and not in healthy controls, showing that it was really the CA-related vascular amyloid that was driving the process, but not the AAD. More recently, Dr. Edip Gurol performed a beautiful study where she also showed that the effect of vascular amyloid on white matter disease is mediated by a measure of vascular dysfunction in patients with cerebral amyloid angiopathy. So a lot of our work is focused on understanding the physiopathologic mechanisms of cerebral amyloid angiopathy and hypertensive small vessel disease, and molecular, functional, and advanced structural imaging are used for those purposes. When it comes to vascular dysfunction, the first study we performed in the first half of 2000s, and we compared the increase in blood flow in posterior cerebral arteries in patients with CAA to healthy controls. And this study clearly showed that patients with CAA had a blunted response to visual stimulus in posterior cerebral artery blood flow, suggesting that there was a decrease in vascular reactivity in patients with CAA because of the relatively heavy vascular amyloid accumulation in the posterior parts of the brain. Functional TCT is a great method to obtain proxies for blood flows, but of course, functional MRI is a little bit easier to perform. It doesn't depend on transcranial Doppler window availability or anything. This functional MRI algorithm was set up where again visual stimulus was used, and the mold response was collected from the visual cortex in the occipital lobes where CA is most pronounced. And this study, comparing again CA to healthy controls, clearly showed that patients with CAA had a slower rise or slower time to peak, a lower amplitude, and a slower time to return to baseline in mold response than compared to healthy controls. This method is being used in even phase 2 randomized trials. It's well established, and the thinking is that in healthy controls or very early stage CAA, there is not much of atrophy, not much white matter disease, and the mold response is rather healthy. But with time, atrophy and white matter disease starts, and the amplitude decreases. So vascular dysfunction starts, and as time goes by, vascular dysfunction gets even worse, which contributes to white matter disease, atrophy, and cognitive impairment. So if I was to tell you guys that CA causes cortical thinning, you would tell me, look, CA and Alzheimer's disease coexist in many patients, so it's probably the Alzheimer's pathology, the pancreatic amyloid and tau that are resulting into thinning of the cortex. But we were lucky enough through Steve to have a strong collaboration with our Dutch colleagues who have a patient cohort of Dutch CAA patients. This is a hereditary form of CAA, and these patients have very little pancreatic amyloid in their brains, but a lot of vascular amyloid. They tend to start bleeding early, and they bleed a lot more often than even sporadic CAA patients. And when we compared these relatively young Dutch type hereditary CAA patients to healthy controls, there was very significant cortical thinning in this group, which we also demonstrated in sporadic CAA patients. And using a mediation analysis, vascular amyloid appeared to play a very significant vascular dysfunction, appeared to mediate the association between vascular amyloid and cortical atrophy. After the discussion of white matter disease in CAA, white matter hyperintensity in CAA, I guess nobody would be surprised when I say that cerebral amyloid angiopathy causes white matter atrophy. So when we compared patients with cerebral amyloid angiopathy to both Alzheimer's patients and healthy controls, CAA patients had more significant white matter atrophy compared to both. And in patients with cerebral amyloid angiopathy, white matter atrophy correlated with executive function scores. So this is one of the ways CAA is affecting cognition. We were working on atrophy, and this study is compared again cerebellar volume, cerebellar cortical and deep cerebellar volume between patients with CAA and AD and healthy controls. Again, showed significant cerebellar atrophy in patients with cerebral angiopathy, and such measures of volumetric measures of atrophy correlated with slower gains. So part of the effect on of CAA on gait worsening is probably mediated by cerebellar atrophy. Pittsburgh compound B proved to bind the vascular amyloid in more than one studies, but KIP is not really easy to use. It needs to be produced on site, and now we have F18-based PET tracers that can label amyloid. And we performed this validation study for fluorobetapir PET to see whether it would be helpful to diagnose cerebral angiopathy. The biggest confounder for CAA-related ICH is indeed hypertensive ICH. So these were the two groups that we compared. And as you can see here, the global fluorobetapir uptake was much higher in patients with cerebral angiopathy, with a mean of 1.41, than compared to hypertensive ICH patients with a mean of 1.15 when it comes to global SUVR. And we went through training for to read fluorobetapir PET scans. So here, if there is a lot of fluorobetapir uptake in the cortex, the contrast between the cortex and white matter disappears. These scans are fluorobetapir positive scans, and all 10 patients had fluorobetapir positive scans, whereas 8 out of 9 hypertensive deep ICH patients were fluorobetapir negative. And as you can see here, the contrast between the cortex and white matter is well preserved. So again, the pathologic studies that tie lower intracerebral hemorrhage to mainly CAA and deep intracerebral hemorrhages and deep microbleeds to hypertensive small vessel disease are out there. Using those criteria, we also aim to validate other MRI markers that can potentially help to differentiate CAA from hypertensive small vessel disease. So we performed quite a few studies using more advanced quantitative imaging methods to come up with patterns of white matter hyperintensity that can make such distinction. They all fail because when the periventricular white matter disease volume is such a driver that whenever you put this in the equation, the advanced neuroimaging based patterns essentially disappear. They do not survive the multiple regression models. Whereas we based on visual observations from over a decade, we looked at a couple of visually identifiable white matter hyperintensity patterns. Multiple spots in the subcortical regions was one pattern. Peribasal ganglia white matter hyperintensity was another pattern. Posterior and anterior patches were the other two patterns. Posterior and anterior patches were not different after correction for age and other covariates. They didn't distinguish CAA from hypertensive small vessel disease, but these having 10 or more spots in the subcortical region on flare was significantly more commonly seen in patients with CAA, whereas this peribasal ganglia white matter hyperintensities were a lot more commonly seen in people with hypertensive small vessel disease. Enlarged perivascular spaces, we used to call them Virchow-Robin spaces on MRI. They are best seen either on T2 or T1. And there was some preliminary data suggesting that presence of more than 20 enlarged perivascular spaces in centrum CMI valley was related to CAA, whereas presence of more than 20 enlarged perivascular spaces in basal ganglia was more commonly related to hypertensive small vessel disease and deep intracerebral hemorrhages. And in a very large group of CAA and hypertensive ICH patients, we have demonstrated these findings. The high degree of centrum CMI PVS was found in about 45% of CA patients versus 18% of hypertensive small vessel disease patients. Basal ganglia enlarged perivascular spaces, severe enlarged perivascular spaces in basal ganglia was a lot more commonly seen in hypertensive small vessel disease than compared to CA. Lacunes are, of course, frequent in people with hypertensive small vessel disease, and they occur in deep brain locations such as thalamus, basal ganglia, brainstem. We aim to look at the presence of these radiologically defined lacunes in the lobar locations. And interestingly enough, so first of all, lacunes were frequent in all intracerebral hemorrhage patients with a prevalence of 25%. These lobar lacunes were more common in CAA, 20% versus 6% when compared to hypertensive small vessel disease. And as expected, deep lacunes, the classical deep lacunes, were a lot more frequent in hypertensive small vessel disease. So these lobar lacunes can be new markers for CAA. And we validated these findings with our colleagues from a large series of intracerebral hemorrhage patients who received both MRIs and Pittsburgh compound B PET scans in Taiwan. This cohort is a very hypertensive small vessel disease enriched cohort. Despite that, we have again confirmed the fact that lobar lacunes were positively associated with Pittsburgh compound B uptake. So probably these lobar lacunes are related to cerebral mediated angiopathy. More recently, Dr. Edip Gurol performed these beautiful analyses in a large CA patient population who received quantitative imaging. And so again, lobar lacunes were present in 25% of CA patients. Cortical microinfarcts were more common in CA patients with lacunes compared to CA patients without lacunes. And by the way, so when I say 25% of CA patients, pretty much all of them, all but one, were lobar when you look at the lacunes in people with CA. So microinfarcts correlated very strongly with lobar lacunes. CA patients with lacunes were more likely to have recurrent intracerebral hemorrhage compared to patients without lacunes. And presence of lacunes and cerebral microinfarcts did not relate to vascular dysfunction. It's an interesting observation because we have previously shown that vascular dysfunction in CA is probably mediating both white matter disease and atrophy, so kind of like global markers of pathology. Whereas for lacunes and microinfarcts, we did not find such an association. Based on all of this work over a period of 10-15 years, we have now some non-hemorrhagic lesions that can be used clinically to potentially differentiate CAA from hypertensive small vessel disease, just based on visual inspection. So multiple spots, as a white matter hyperintensity pattern that is more commonly found in CAA. Peribasal ganglia white matter hyperintensities is more related to hypertensive small vessel disease. Lobar lacunes, again, related to CAA, whereas classical deep lacunes to hypertensive small vessel disease, and centrum CMI ovale enlarged perivascular spaces, again, related to CAA, whereas the deep basal ganglia, enlarged perivascular spaces to hypertensive small vessel disease. Several small vessel diseases cause intracerebral hemorrhage, microbleeds, superficial siderosis through vessel rupture. They cause white matter hyperintensities and brain atrophy through vascular dysfunction. The exact mechanisms of lacunar infarcts and microinfarcts are less well known, but they appear to be clearly related to these small vessel diseases. All of these global and micro lesions can cause direct damage to critical structures and can cause global network dysfunction, both structural and functional domains, and leading to impairments in cognition, gait, and other motor functions. There are a lot of detailed review articles on this topic. So if you guys are interested, you can contact me or like easily find others. But this is a fairly advanced neuroimaging in several small vessel diseases is a fast developing field, and I have been really happy and honored to be part of this effort over the past 20 years. Clinically, several small vessel diseases are known to be major cause of all intracerebral hemorrhages, including coagulated ICH. These data came from studies that Jonathan Rosen and Steve Greenberg performed together with multiple other investigators back in 1990s and even early 2000s. One important issue is to try to stratify the risk, because if such patients need anticoagulant treatment or antiplatelet treatment, then it might make a difference to know the risk of recurrence of intracerebral hemorrhage or the risk of a first-time intracerebral hemorrhage if the patient only has markers of fibrillation risk without a bleed. So this study looked into such recurrence risks in people who had a purely deep intracerebral hemorrhage plus minus deep microbleeds. The annual risk of recurrence was 1.6% per year, which is about 16 times higher than compared to general population that are similarly aged. In patients with cerebral angiopathy-related ICH, the incidence of ICH, recurrent ICH, was about 10% per year. That's the mean. You can certainly further stratify this, which we will discuss. And we came up with this new category of patients who had either a deep intracerebral hemorrhage and superficial microbleeds, or lobar intracerebral hemorrhage and deep microbleeds. And we call this mixed intracerebral hemorrhage cerebral microbleeds. So the features, the other imaging and clinical features of this mixed location ICH microbleed population resembled the severe hypertensive small vessel disease population, and the annual risk of recurrent bleeding was much higher than deep ICHs, which was 5.1% for these mixed location ICH microbleed cases. Again, we went to Taiwan, and we have used their great cohort of Pittsburgh compound B and MRI scans intracerebral hemorrhage patients. In Taiwan, hypertension is endemic, and like the great majority of these patients have hypertension. What we figured out was that 55% of their population had mixed location ICH microbleeds, and the Pittsburgh compound PET result confirmed our initial findings. Essentially, as you can see here, patients with CAA had a lot of amyloid in their brains, whereas hypertensive ICH and mixed location ICH microbleed patients had much less amyloid, again, suggesting that people with mixed location intracerebral hemorrhage and microbleeds probably have a more severe form of hypertensive small vessel disease, but not cerebral angiopathy. What happens if someone with mixed location ICH microbleeds also have superficial siderosis? So there were only 5 patients in this cohort which fit this particular category, but they had a lot more amyloid in their brain, suggesting that the presence of superficial siderosis is probably fairly specific for the CAA. And Dr. Alvindas recently worked on that particular issue, and he looked at the imaging and clinical variables that are known to be related to either hypertensive small vessel disease or CAA. And in people with mixed location intracerebral hemorrhage and microbleeds, if there was cortical superficial siderosis, these people were more likely to have the multi-spot white with hyperintensive pattern and more severe central semi-ovale and large perivascular spaces, suggesting that, once again, if you have superficial siderosis, these people do have at least some degree of cerebral angiopathy pathology. So I say it etiology made simple. If you have someone with strictly cortical intracerebral hemorrhage or microbleeds and or cortical superficial siderosis, so that typically represents cerebral angiopathy, regardless of supratentorial or infratentorial locations. If in someone who has strictly deep or mixed location ICG and or microbleeds, if there is no superficial siderosis, the underlying pathology is probably hypertensive small vessel disease. If a patient has strictly deep or mixed location ICG and or microbleeds with cortical superficial siderosis, so that might represent real mixed pathology, hypertensive and CAA. What happens in people who only have microbleeds is the next question. And this was a study that one of our fellows, Edip Gurol, performed about 10 years ago now. It's a highly cited paper. Here, she looked at the patients who had strictly cortical multiple microbleeds. These patients, ApoE status, clinical features, and other radiological features were very similar to patients with CAA who had a lower intracerebral hemorrhage. And even in those people who had just cortical microbleeds, the risk of first-time intracerebral hemorrhage was very high. It was about 5% per year. And Coumadin use and older age were independent predictors of first-time intraparenchymal hemorrhage in this patient. These findings were somehow confirmed in multiple prospective studies, one of which was the PROMISE-2 study, where they enrolled people with acute ischemic stroke or TIA, who had atrial fibrillation, who were kept on anticoagulants. And in this patient population, if the baseline MRI showed microbleeds, the risk of a intracerebral hemorrhage in follow-up was about 4 times higher than compared to patients with MRIs that did not show any microbleeds. This was confirmed in a, again, large-scale prospective study, similar design from Spain, and both the presence of microbleeds on MRI and presence of moderate to severe white matter disease on MRI were associated with a higher risk of intracerebral hemorrhage in these anticoagulated patients. For patients with cerebral angiopathy, if you want to further stratify the risk of recurrent intracerebral hemorrhage, cortical superficial siderosis is an important marker. If there is no superficial siderosis at all, the annual risk of recurrence is about 5% per year. It's still extremely high. So, like in this patient population, the annual in a general patient population with similar ages, the annual risk of intracerebral hemorrhage is about 0.1% per year. When I compare this to 5% per year, we are talking about a 50 times higher risk. But this can give you good information for temporary use of anticoagulants or other antithrombotics. Because if a patient has only one region, if a patient with CA has only one region with superficial siderosis, then the annual risk of recurrence is 6.5%. It jumps to over 13% if there are 2 regions with superficial siderosis. And if there is widespread superficial siderosis, as you see here in score 4, the annual risk of IC recurrence is about is over 28%. So These data can help one certify the risk of intracerebral hemorrhage in patients with cerebral angiopathy. Another study that Dr. Alvin Dusk performed, again more recently, he compared MRI findings and clinical features in people who had direct oral anticoagulant-related intracerebral hemorrhage to people who have been kept on direct oral anticoagulants and never had intracerebral hemorrhage. And cerebral microbleeds, the presence of cerebral microbleeds, the presence of cortical superficial siderosis, as well as the past history of ischemic stroke, diabetes, and smoking history were significantly associated with the risk of developing direct oral anticoagulant-related intracerebral hemorrhage. So when we see those, even in people without a history of intracerebral hemorrhage, we should know that such patients have significantly higher risk of developing intracerebral hemorrhage on anticoagulants. Now we are going to discuss, in the rest of the talk, we are going to discuss the links between small vessel disease and non-valvular atrial fibrillation. As you guys know, non-valvular atrial fibrillation increases the risk of embolic strokes, and direct oral anticoagulants are used to decrease such risk. But there is reason to be worried about the risk of intracerebral hemorrhage in people with AFib who have high brain bleeding risk. But why do we care about this? The answer is simple. Even DOACs, they increase the intracerebral hemorrhage risk by 2 to 5 folds, even in very low risk populations. And when an intracerebral hemorrhage, when a brain bleed happens in a patient who was on direct oral anticoagulant or warfarin, the outcomes are horrible. As you can see, mortality of warfarin-related ICH in Radiological and Aristotle. These are the phase 3 studies of the two most commonly used direct oral anticoagulants, which are apixaban and rivaroxaban. In a rivaroxaban study, warfarin-related intracerebral hemorrhage had a mortality of about 50%. Rivaroxaban-related intracerebral hemorrhage had an immediate mortality of 48%. These are horrible results. And in Aristotle, the warfarin-related ICH mortality was about 43%, whereas apixaban-related ICH mortality was over 45%. We knew these figures from warfarin studies, but unfortunately, when you have a direct oral anticoagulant-related ICH, the outcomes are not really better. So now, people who had a past history of intracerebral hemorrhage have been excluded from all randomized controlled trials of direct oral anticoagulants and warfarin. So we had no data about how these drugs would kind of behave in people who had a past history of intracerebral hemorrhage, if they had atrial fibrillation, and if they were put on oral anticoagulant. Two studies have been performed. I'm just going to give a quick summary. It's very difficult to enroll these patients because they die when they have AFib patients, when they have a intracerebral hemorrhage, especially on oral anticoagulant. 50% of them die and 30% remain severely disabled. So these two studies that focused on similar patient populations with few differences. So these were essentially people with atrial fibrillation who survived an intracerebral hemorrhage. And they were randomized to either direct oral anticoagulants versus aspirin or nothing. So a total of 304 ICH survivors with AFib, followed up for 1 to 2 years. 15 recurrent intracerebral hemorrhages occurred when DOAC was started after ICH, and there was 7% mortality for DOAC-related ICH. 2 recurrent intracerebral hemorrhages happened when oral anticoagulant was avoided, and none of the 2 was fatal. Recurrent ICH in past ICH survivors was more than 7 times higher with DOAC treatment, and rates reached 10% per year. And DOAC failed to show non-inferiority against aspirin and nothing in ICH survivors with non-valvular atrial fibrillation in the SOLSTAR study. That was one of the endpoints of this trial, and it failed to show non-inferiority against aspirin or nothing. So the next question is there any alternative to lifelong anticoagulation in atrial fibrillation? Surgeons since 1950s knew that in people with atrial fibrillation, most of the thrombi, most of the clots happen in left atrial appendage. So they were sometimes solving it or stapling it, even in 1950s, 1960s, and afterwards. This first meta-analysis from 1996 showed that 91% of clots in non-rheumatic atrial fibrillation happen in the left atrial appendage. And a lot of other studies showed up to 100% of the non-valvular afibrillated clots happening in the left atrial appendage. This is what led some to call the left atrial appendage as our most lethal human attachment. Endovascular devices have been developed to less invasively close this appendage. So this one is a cath lab-based procedure. They use the catheter to cross the atrial septum, find the left atrial appendage, and place a device. Now, in the United States, Watchman Flex, which is second generation Watchman, and Applastic MLA are two devices that are FDA approved. The initial study, most of the studies have been performed using Watchman and Watchman Flex. The initial studies showed a very significant decrease in hemorrhagic stroke when compared to Coumadin, and even when indirectly compared to direct oral anticoagulants. But there was some increase in with Watchman in ischemic stroke risk when compared to warfarin, although it showed non-inferiority. That was a red flag. Under these circumstances, FDA approved the Watchman device, now the Watchman Flex, to be used in non-valvular atrial fibrillation patients who are at increased risk of stroke and systemic embolism on the basis of CHAS2 or CHAS-VASc scores, and that is CHAS2 more than 1, CHAS-VASc more than 2, deemed by their physicians to be suitable for either oral anticoagulants, which might be warfarin or direct oral anticoagulants, or dual antiplatelet therapy for anywhere between 6 weeks to 12 weeks, and who have an appropriate rationale to seek a non-pharmacological alternative to oral anticoagulants, taking into account the safety and efficacy of the device compared with oral anticoagulants. I really love the wording. So they essentially say if you're concerned about bleeding or about patient not taking the drug appropriately, consider left atrial appendage closure instead of lifelong anticoagulation. So essentially, after this procedure, either warfarin or DOAC or dual antiplatelets are used for up to 6 weeks. And after 6 weeks, it is typically dual antiplatelets for another 4.5 months. And after that, it's just aspirin, but a lot of different alternatives have been used. So these are the results of a recent randomized controlled trial that compared left atrial appendage closure using either Watchman or Amplatzer MLA to direct oral anticoagulants. And the cumulative rate of a composite outcome was very similar. If anything, left atrial appendage closure seemed to be a lot better than direct oral anticoagulants in this study that had 4 years follow-up. Another recent study that employed left atrial appendage closure in patients undergoing major cardiac surgery, whether for coronary artery bypass grafting or valve replacement, valve repair. But these people were randomized to either, they had to have atrial fibrillation, and they were randomized to either closure of the left atrial appendage versus not closing the left atrial appendage. People who had their left atrial appendage closed were much less likely to have ischemic strokes in follow-up. So there was a 33% decrease in risk of ischemic stroke in this patient population, despite the fact that both arms used oral anticoagulants similarly. If anything, people without the left atrial appendage have been more likely to use the oral anticoagulant during follow-up. So we have an alternative. It is not without risks. It's a procedure. It is a 0.5% risk of sustaining a stroke or rather significant damage to the heart. It's 0.5%. It's not nothing. But in good hands, this has become a fairly safe procedure. And like all anticoagulants, it's not, it can also fail. And people might have ischemic strokes or intracerebral hemorrhages even after this procedure. So I don't have too much time remaining, but yeah, the other link is between small vessel disease and atrial fibrillation is ischemic strokes in people with atrial fibrillation. So they might be embolic versus small vessel disease related. We are conducting this multi-center neuroAFib study. We completed the retrospective phase, working on the manuscripts. Prospective phase is ongoing, and so we are enrolling people who get admitted to U.S. academic stroke divisions with either an ischemic stroke or intracerebral hemorrhage, who either have a known history of AFib or who are diagnosed with atrial fibrillation during admission. A very detailed overview of clinical lab and imaging data is obtained, and the small vessel disease imaging profiles are obtained in all of these patients. So doing that, we are identifying DOAC, warfarin, and left-sided appendage closure failures, their risk profiles, their concurrent etiologies. So we are trying to further characterize people who had a non-atrial fibrillation, but who were not using any FDA-approved prevention measure. Again, we are trying to identify people with atrial fibrillation unknown prior to ischemic stroke, and to see whether the risk profiles can help identify a set of patients who can be more efficiently monitored for atrial fibrillation. And all of these questions that we discussed regarding atrial fibrillation, intracerebral hemorrhage, or the anticoagulants are also addressed in this study. So the preliminary results show that we are failing a lot. In the United States, in just 1 year, we see about over 40,000 DOAC failures, close to 30,000 hemorrhage failures, about 70,000 afibrillated ischemic strokes who were not using any FDA-approved prevention method despite non-diagnosis of AFib, over 40,000 afibrillated ischemic strokes without past history of non-AFib, and these patients indeed have poor outcomes. And if a patient fails oral anticoagulants, the patient with atrial fibrillation fails oral anticoagulant, the annual recurrence risk is about 8.9% per year. These multi-center prospective data was confirmed by another study that we performed in the United States. And again, people who had an oral anticoagulant failure, people with AFib who had an oral anticoagulant failure were a lot more likely to have a recurrent ischemic stroke after this failure. And switching DOAC to a different DOAC or adding aspirin, these things did not make any difference. One of our current fellows, Dr. Edip Gurol, is working on worked actually on a study where she identified patients who received left-sided appendage closure for the indication of oral anticoagulant failure. So, left-sided appendage closure is very seldom performed in this patient population, but Avia performed a meticulous work within the whole Mass General Brigham system and identified 29 patients, and over 1.75 years of follow-up, the annual recurrence rate of ischemic stroke in people who underwent left-sided appendage closure was only 1.97 per 100 person years, as opposed to 7%, 8%, 9%, the data that have been reported in the literature. And another group from Europe have similar results. So if left-sided appendage closure is used after in patients with ischemic stroke while they were prescribed direct oral anticoagulants or warfarin, the annual recurrence rate is down to 2.2%. From 9.8% if left-sided appendage closure was not performed and they were only kept on oral anticoagulants. Cognitive impairment. So atrial fibrillation can cause cognitive impairment through either embolic strokes or decreased perfusion. The one big problem so far in those studies is that if the neurologists are performing a study of atrial fibrillation with cognitive impairment, they only include MRI markers. They don't include a single marker of the severity of atrial fibrillation or AFib typically. And if cardiologists do it, they do not include any MRI markers. They only focus on risk factors. So questions are, can left appendage closure be a better method to prevent cognitive worsening in people with atrial fibrillation? That one was a non-randomized study that enrolled about 100 patients with AFib who received catheter ablation for atrial fibrillation. And they got MoCA scores at baseline and MoCA scores at follow-up. Interestingly enough, people who had a left appendage closure, they didn't have any significant worsening of their cognitive scores, whereas people who were kept on oral anticoagulant after catheter ablation had a very significant worsening of their cognitive scores. That might be explained by asymptomatic embolism. It's an interesting finding. Of course, it's going to require a randomized controlled trial. When it comes to rhythm and perfusion issues, the early rhythm control was associated with a decrease in risk of stroke in a randomized controlled trial of early rhythm control versus standard approach in patients with atrial fibrillation. And there are some data that also suggests that catheter ablation can lower the risk of incident dementia and mortality in adults with atrial fibrillation. One important issue to remember is that that kind of data are not randomized, so we do need randomized controlled trials to see whether correcting the rhythm disorder in atrial fibrillation might improve the cognition. So these are our conclusions. Hypertensive, small vessel disease, and CA are major causes of brain microangiopathies in middle-aged and older adults. Several small vessel disease cause vascular dysfunction, resulting into global ischemic damage that manifests as white disease and brain atrophy. Small vessel disease also causes intracerebral hemorrhages, lacunar infarcts that can be all asymptomatic. Intracerebral hemorrhages are almost invariably symptomatic. But also smaller ischemic and hemorrhagic lesions, including microbleeds, superficial siderosis, microinfarcts, and large perivascular spaces. The accumulation of smaller and larger lesions cause vascular cognitive impairment, gait, and other motor disorders. Atrial fibrillation causes embolic brain infarcts and brain perfusion changes that are contributing to VCI, but exact mechanisms are unknown. And stratification of the risk of coagulated, fatal, or disabling intracerebral hemorrhage and constellation of non-coag alternatives is important in patients with small vessel disease who also have non-valvular atrial fibrillation. So with that, I would like to thank you guys for attending either in person or through Zoom. I had a lot of people to thank. I'm always fear to miss people, so yeah, the patients and families are so important in clinical research. Our residents and fellows always inspire us with their clinical questions. The funders certainly play a big role, and my collaborators in Boston, the United States, and worldwide, including my philanthropic supporters. So thanks for your attention, and I think we have some time for a few questions.
Thanks for wonderful talk. For all the collaboration, skill of leaders. One question we talked about before, but I think you're so we've heard doctors issue with high temperature, issue with non-violent, also the higher chance of death, or we've heard doctors so they go ahead and that they can potentially provide required some period of anticoagulation or any trauma treatment. How do you represent this development?
Thank you so much. So, guys, we did not set this up. I haven't seen Steve for a little while, but that's an excellent question. So, I mean, here's the good news. Yes, that was a problem. The first generation Watchman required essentially initially warfarin plus aspirin, although we tweaked that and like they used the Doax without any problem. The second generation Watchman, better device with much less risk of peri-device leaks, much less risk of device-related thrombus. Now the third generation is coming within the next few weeks. It's going to be an anti-thrombotic coated device. The preliminary data are excellent. FDA is likely to, so this is kind of confidential, but FDA is gonna probably approve it within the next couple of weeks, and it should be in use possibly by the end of this year or next year. So the preliminary data come from studies where they use only baby aspirin essentially. So that might really change the approach to those like high bleeding risk patients. And amplaceramide, Abbott guys are also work. So amplaceramide has been the second generation. It required dual antiplatelets for 3 months and then aspirin. I don't know what they are doing, but there is likelihood that they're also working on a coated device. So with the improvement of devices, like this procedure has improved, it might be that might just require aspirin from the day of the procedure now. I hope that was an answer to your question of what to do during those 6 weeks, 12 weeks, or of anticoagulants.
Okay, the graduation will be a basic body of the bodies and the lungs. I think I'm really impressed with what we've accomplished. Question related to the patient and the physician. Very particular. It's the changes we receive. It's my understanding that the vision for these amyloid, the CEA transition is superficial. Yet the changes we see deep. Do you think the vascular bed or is it more regular?
Yeah, F18. So I think Anish asked about CA is a superficial disease, a cortical disease, and Alzheimer's disease is the same. So we should be seeing the amyloid in the cortex. Why in the fluorobeta PET study we have shown I mean, a lot of deep uptake. So F18 products, all of them invariably they have off-target binding in white. So that's not so like you don't see this with CRISPR compound B, but all of the F18 products, their big advantage is that their half-life is 4 times higher than the CRISPR compound B. So they are commercially available. They are produced in one center in large cities, and they can be distributed to several different hospitals and facilities. But yeah, they have a lot of off-target binding in white matter, which we know about it. This is why, like, we are using this. Is there contrast between cortex and white matter or not? So if there is contrast, there are not that much of like amyloid in the cortex. If this contrast is lost, then you are looking at like mostly all of target binding in the white matter and like a lot of amyloid in this. That's a very good question. You're not seeing this with CRISPR compound.
I thank you for this wonderful journey through CAA, FIG, two questions. How do they compare this with pathology? So small vessel bleed from CAA compared to regular disease. And the second question is a little more speculative. Do you think in the future that every age patient should have an MRI or should follow with MRIs prior to? What's your opinion?
Thank you so much, Barbara, for these excellent questions. So the first question is the pathology in CA versus hypertensive small vessel disease. So cerebral amyloid angiopathy is characterized by accumulation of mainly the soluble amyloid, A-beta 40 types in the cortical vessels and leptomeningeal vessels. So this is where like you see the pathology, and Yeah, this is where we see evidence of vascular dysfunction. And most of the findings, all of these enlarged perivascular spaces in the centrum ovale, multiple spots, and of course, cortical microbleeds, lobar hemorrhages, they are all superficial. So it's more of a superficial pathology. The exact mechanisms of CA-related damage, we do not know. I think it would require, it would take another grand round to discuss it, but certainly it kind of like replaces the media, and then you might see microaneurysms or double barrel type of appearance, and finally it either leaks or ruptures and causes microbleeds and macrobleeds. For ischemia in CAA, vascular dysfunction would explain the global injury, which is white blood hyperintensity, white blood atrophy, cortical atrophy. But interestingly enough, we didn't correlate really with like presence of lacunes or microinfarcts. So these, again, small vessel disease related findings are probably related to destruction of individual vessels. We don't know exactly how. When it comes to hypertensive small vessel disease, the bulk of the data is still coming from Charlie Miller-Fisher. So hypertensive arterial sclerosis, and so that's a process that happens mostly in deep perforators. But our work and others' work, like all of these data, have been confirmed by multiple studies. So hypertensive small vessel disease is mainly a perforator disease. At these branching points, it causes some lipoiodinosis, which can go on to essentially destroy these small vessels to cause lacunes. But again, it's also a very big contributor to white matter disease. For hypertensive small vessel disease, the CBRIMR put CA on the map, and like hundreds of studies have been published. Unfortunately, hypertensive small vessel disease, despite the fact that it is a lot more common, has never been that sexy to clinical practitioners or researchers. We are trying to kind of engage people to augment research in that part of their field, but need a lot more data. Okay, looks like we are on time. Wow, 10:04. Okay, thank you so much for attending.